Welcome, everyone. This is the Penguin webinar for the AIM Perinatal Mental Health Conditions Bundle. My name is Kaylee Vitek, and I'm the Penguin Project Manager for our obstetric initiatives. We have a full agenda today with 3 great presentations, so I'm going to move as quickly as I can through our opening slides and then turn it over to our first presenter. Here we go. All right. Usual Penguin Zoom housekeeping items, please type your name and institution into the chat. Our optional share for this month in the spirit of the holiday is, what are you feeling grateful for today? A reminder to mute yourselves when you're not speaking. Please feel free to type your questions into the chat during the webinar, and we'll have about 10 minutes for question and answer at the end of our presentations. And this session is being recorded and will be uploaded to our website along with slides in about a few days. So like I said, we have 3 great presentations. I'll just move along and just ask that our presenters briefly introduce themselves when they start their presentations. Reminder that these are our mental health bundle teams. We have 23 formally signed on to participate, and there is still time to participate if you would like to. This is a reminder of our onboarding steps and participation steps. Again, these slides will be posted and these steps will be sent out via email. This is our Perinatal Mental Health Conditions Bundle work group working really hard in the background to help bring you this webinar content as well as resources. We have a toolkit in the works that we'll be excited to share with you in the coming weeks that this group has been working really hard on. Okay. So just a few reminders from Penguin. Our Fall Summit is coming up on December 9th in Norwood. We've reached our registration capacity, but you are still able to add your name to the wait list. So if you're no longer able to attend the summit, please do cancel your registration so that someone from the wait list can join. And people do cancel in these weeks coming up. So it's definitely worth it to add your name to the wait list and see if you can make it. We have a few new resources on our website, including an updated Likert scale appendix for answering AIM bundle structure measures, some really great information from our fellow PQC in Utah on birth trauma, and the recording of a webinar from MCPAP for Moms on postpartum psychosis. If you tuned in to this series last month, one of our work group members with lived experience with postpartum psychosis shared her story, and it was really powerful. So if you're looking to learn more about that condition, there's a whole webinar on it from our partners at MCPAP. There's a new publication out around levels of maternal care with contributions from Penguin's Dr. Fifi Diop and the Betsy Lehman Center's Dr. Godwin Osei-Poku. So if you're interested in levels of care, be sure to tune into that. And we have a section on our website for publications. So if you've worked really hard on a publication about your Penguin work and want it featured on our website, please do send it to us. Coming up for events for Massachusetts, the Health Policy Community in Mississippi Delta webinar and in-person reception is coming up on December 3rd. The Expanding the Circle of Support in the Perinatal Period training series from Mass PPD Fund has 2 more training dates on December 5th and January 14th coming up, so do take advantage of those. We also have a request out from Mass DPH. They'd like to connect to hospitals that are planning or may already have a hospital-based doula program. So if you are planning one or have one, please use the links on this slide and in my follow-up email to connect with DPH. And lastly, our partners at the Institute for Perinatal Quality Improvement are putting out their 28-day anti-racism challenge coming up in February. They revise the challenge every other year. So this year there is coming out with version 3. So there's new content, new opportunities to reflect, learn, and act and support your efforts to dismantle racism in your workplace and community. And finally, we just heard about this terrific webinar, which is very relevant to the presentations you'll be hearing today. HRSA is putting out a roundtable on culturally and linguistically appropriate screening for perinatal mental health and substance use disorder on December 5th. So be sure to register and tune into that, especially after hearing the wonderful presentations we have today. So with that, I'll turn it over to our first presenter, Dr. Tiffany Moore Simas.
Hi, good morning, everybody. Tiffany Moore Simas. I'm a general obstetrician gynecologist, a chair of OB/GYN at UMass, and helping lead the perinatal mental health conditions patient safety bundle implementation with PinQuin. We can go to the next slide. So the focus today is on screening. I just want to sort of reorient us. When the AIM bundle talks about perinatal mental health conditions, we're talking about mood disorders, so depression and bipolar disorder. We're talking about anxiety and anxiety-related disorders, which the anxiety-related disorders are mostly referring to PTSD, OCD, and then, from a mental health conditions perspective, the bundle also addresses postpartum psychosis. We can go to the next slide. From a screening perspective, what we really are predominantly talking about is screening for depression and anxiety for everybody across the board and bipolar disorder. I will say in our own practice, we do screen everybody, but minimally before pharmacotherapy initiation. So we'll talk about that. The very first of the 5 R's in the bundle is around recognition and prevention. I'm sorry, this is actually the second R, recognition and prevention for every patient. We can go to the next slide. And so the first step in that recognition and prevention for screening is to obtain an individual and family mental health history. Next slide. I almost jumped over this because it seems like pretty intuitive what that means, but just in case, from an individual history, for many of the patients we see, they will come into their initial prenatal visit or will come to our labor floor, with a known current diagnosis and a treatment plan in effect. So understanding what the no diagnoses are, what the treatment is, the first step in that understanding individual history. Of course, the second step is understanding past psychiatric diagnoses. There are some people who have had past diagnoses that won't necessarily reveal that when you say what's current and have undergone past treatment, and the intensity of that treatment, whether or not previous psychiatric hospitalizations have been involved, and whether or not they've had previous suicide attempts is, of course, really relevant and valuable information as we're getting to know the risk for the patient that we are caring for in the moment. And then anybody who has a family history of mental health conditions, of which most of us do, that's relevant to know what some of those underlying predispositions may be, both from a genetics perspective and from a lived environment experience perspective, because we know there are a number of social determinant drivers of health that increase the risk for mental health conditions. Next slide. So once you get beyond that individual and family health history understanding, there is a recommendation for screening for depression, anxiety, specifically at the initial prenatal visit, later in pregnancy, and at the postpartum visit, ideally including pediatric well-child visits. I appreciate many of you who are engaged in implementing this bundle and who are on the webinar really are doing implementation at the hospital level. And so I appreciate, at that, delivery discharge is also a time when people are doing it. If we go to the next slide, the ACOG recommendations around screening mirror exactly this. So that second recommendation says exactly the same: initial prenatal visit, later in pregnancy, and at postpartum visit. And the first recommendation speaks to really across the reproductive life course and not just in the perinatal period, but very specifically speaks to using standardized validated instruments, which is what we'll get into next in the next slide. So there are a number of different validated screening tools, and I specifically pulled these out for depression, anxiety, because the bundle and the ACOG recommendations specifically speak to screening for depression and anxiety. There are screening tools around PTSD, OCD, and others. Really, the focus is around depression, anxiety in the bundle and in the recommendations. The three instruments I pulled out were for depression, PHQ-9 and EPDS, and for anxiety, the GAD-7 and the anxiety subscales of the EPDS, which are questions 3, 4, and 5. The reason I pulled these 3 out specifically is there is the greatest literature base as it relates to these instruments in the perinatal period. These are certainly not the only instruments. There are actually many, many more, but these are those with the greatest literature base. They tend to be, quote unquote, easy to administer. They are filled out by the patient themselves. Many of these have been validated in other languages, and they're sort of, relatively easy to score. So they're the most commonly utilized. They're the ones with the greatest evidence base behind them. And so these are the ones that were highlighted in both the patient safety bundle resources and the clinical practice guidelines from ACOG. You can go to the next slide. I do want to point out that these are screening instruments, and so there is an assessment that should follow the screening instrument. However, the scores of these screening instruments do tend to correlate with the severity of illness, and that severity of illness often directs treatment intensity. So screening instrument, not diagnostic tools, and they do have a correlation with disease severity. Next slide. This is a table directly from the ACOG clinical practice guideline, which again speaks to a number of the different conditions we're asked to screen for, a number of the different screening instruments, some information around how many questions are there, are they self-administered, the sensitivity and specificity, and what a positive screen means. What's the cutoff value for that? Go to the next slide. I will point you to we have a bundled toolkit coming, and also the Lifeline for Moms team has a toolkit, and in that are all these screeners sort of consolidated into one place. Many of these are also in your EMRs for those that have them. It's important to remember for the depression screeners in particular, there is usually one question in the PHQ-9, it's the 9th question, in the EPDS, it's the 10th question, that specifically speaks to self-harm. And the recommendation is that if somebody answers, yes to a self-harm question or suicide question, then we really need to assess that. So when you're looking at the screeners, you're looking at an overall score, but you also want to look at the self-harm question independently. We can go to the next slide. So, as I said, in the EPDS, it's question 10, and the PHQ-9, it's question 9. So anything other than never in the EPDS question 10 or 0 on the PHQ-9 should prompt some additional questioning. We can go to the next slide. I will say the vast majority of people that answer a 1 or hardly ever do not have active suicidal ideation, but similar to the screeners, once you have a positive screen, you should go on to a further assessment. That is true of this individual question too. Like if it's positive screen for self-harm, we should be going on to ask additional questions. And, when people answer something other than 0 or none, it's often on a large range of kind of from morbid ideation. I guess I'm just finding myself thinking a lot about death lately with no intent, no plan, etc. Very low risk to all the way up to high risk with that intent. The house is empty. I'm going to hurt myself tonight, and has a plan. We can go to the next slide. And there is, along this similar vein, sort of low to high risk, somebody who's in the lower risk category of acting on this, and we'll have a psychiatric emergencies webinar later on, in which we'll get much deeper into this, but no prior attempts, if prior attempts, low lethality, high rescue potential, no plan, no intent, no substance use, and lots of protective factors like family support, future focused when they're talking about plans for their baby's first birthday or what have you. That's a much lower risk situation. We can go to the next slide. I think many of us, and I would put myself in this category, historically have been sort of uncomfortable asking questions, historically or still are uncomfortable asking these questions. So in that Lifeline for Moms toolkit, there is some verbiage to sort of help introduce the concept of assessing for self-harm, more specifically. So many people have intrusive or scary thoughts. When people are sad or down, they often have thoughts about death or wanting to die. These thoughts can be awful, and they sometimes feel, they can sometimes feel reassuring or like an escape from a hard life or something else that feels too hard to bear. We are here to help you. we ask about these thoughts because they are so common. So trying to take the stigma out of it, trying to normalize in a way that would open up somebody to be able to talk. And then you can build up to asking about the suicide risk. So, here's some questions to offer, and here's some additional questions to ask about suicide risk. In the past 2 weeks, how often have you had thoughts of death or wanting to die? When we built these toolkits, we did ask persons with lived and living experience. Some of the things people said to them that they really found like memorable in a negative way, like that were really off-putting, stigmatizing, and shut them down, versus, and what people said that opened them up, made them feel like they were safe to be able to share, decrease stigma. And so when we put together some of the suggested language, they came from, persons with lived and living experience, and others, suggested language came from other tools. We can go to the next slide. I know when I talk to some people, they are, this is where they can be most uncomfortable in trying to assess the answers to those questions. And so there are suicide screening tools also. I offer 2 here. One is the Patient Safety Screener, and the other is Columbia Suicide Severity Rating Scale. So you could use this as a screener also, once you have a positive screen on the like PHQ-9 or the EPDS. Next slide. And then the last part of the recognition and prevention, 5 R's for the patient safety bundle, is screening for bipolar disorder before initiating pharmacotherapy for anxiety and depression. Next slide. That also corresponds with the ACOG recommendation for screening for bipolar disorder before initiating pharmacotherapy for anxiety or depression, if not previously done. And the reason it says if not previously done is because there is not a strong recommendation, but at least a suggestion from ACOG to screen everybody for bipolar disorder. So minimally, we can go to the next slide, we want to do it before we prescribe pharmacotherapy for depression or anxiety. And this is, in the last webinar, if you were there, we did a Pearl around postpartum psychosis. 70% of those with postpartum psychosis will actually have bipolar disorder, and prescribing an unopposed antidepressant can precipitate mania and increase risks of other negative outcomes like suicide and infanticide. And of those that screen positive for perinatal depression, almost a quarter will actually have bipolar disorder. So before prescribing, if you already don't know about a history or risk for bipolar disorder, you want to make sure you do. And there are 2 bipolar disorder screenings. One is the mood disorder questionnaire. This is the one in our practice we give to everybody as, sort of a packet. They do the EPDS, they do the GAD-7, they do the bipolar disorder screen, substance use disorder. We package this all together. And then we have that information going forward. For the PHQ-9, the EPDS, the GAD-7, it says in the past, depending on which one we're talking about, the last 7 or 14 days. And so those screeners we give over and over and over again because one's, condition can change. Versus the bipolar disorder screeners are quote unquote for lifetime risk. And I will say most of our patients have not lived a lifetime yet. So we do repeat this over the course of in a different pregnancy. So like we would do it again in the second pregnancy, but when we give it at the initial prenatal visit, we consider it to be what we, that we have done the screener for the pregnancy and the postpartum period. Now, of course, if somebody's demonstrating symptoms of mania, et cetera, we would reevaluate this. And then we can go to the next slide, the little black box at the bottom with the writing. This is called the CIDI, the Composite International Diagnostic Interview Bipolar Disorder Screen. Unlike all the other screens I've talked about before now, this one is not self-administered. This is one, we actually have an app where you could just sort of pull it out of your pocket and read the questions to the person in front of you. So you ask question 1, you ask question 2. If you have a yes answer to question 1 or 2, you would ask question 3. If there's a yes to question 3, then the screen suggests the patient may have bipolar disorder. And at that point, you would not want to be prescribing an unopposed antidepressant. I would say in our state of Massachusetts, I would call MCPAP for moms, or depending on where you are, your sort of inpatient psychiatry team or what have you. I think next and last slide, I believe. Oh, 2 more slides. So if we put the framework for perinatal mental health education and screening, and we sort of take all the recommendations from the bundle, ACOG, American Academy of Pediatrics, American Academy of Family Medicine, it would look something like we would screen in each trimester, we would screen at childbirth, we would screen in the early part of the postpartum period. And then, for our pediatric colleagues on the phone, we'd certainly screen at all the postpartum, the well child visits in the pediatric setting. Next slide. And the why for that is that, if we think about when do these mental health conditions have onset? About a third of individuals will come into pregnancy with a mental health condition that they may or may not know about. So that early screening is to pick those up. The screening in each trimester of pregnancy or later in pregnancy, depending on which recommendations you are, and with the bundle and with ACOG, they're saying basically one time later in pregnancy. It's about picking up the third that will develop it over the course of pregnancy. And then every time we ask, we're sort of opening the door, we're decreasing stigma and saying we care about this and we want to know. And then, prior to discharge from a hospital birthing center, that may for some people be the first and only interaction they have with the medical community. And so that is an opportunity both for education and screening. And then postpartum is about picking up the postpartum onset, acknowledging baby blues super common in those first couple of weeks. Within the first 3 weeks postpartum is at greatest peak onset of postpartum psychosis. And then throughout that first postpartum year, we need to think about peak onset of perinatal mental health disorders or in the 3 to 6 months postpartum, and peak incidence of suicide is 6 to 9 months postpartum, which is often when the connection with the obstetric community is less, but the well child visits are happening, and hence the recommendations to our pediatricians. I believe this is the last slide, which is just a summary to remind ourselves. So in this R of recognition and prevention, screening includes individual and family mental health history, screening for depression, anxiety at these multiple time points, and screening for bipolar disorder before we initiate pharmacotherapy. So thank you.
Thank you so much, Dr. Moore Simas. Lots of great information there. And again, this recording will be available on our website along with the slides, so you can take a closer read at everything that was presented. And now we're going to turn it over to Linda Getchell from Milford Regional Medical Center to share with us about their work on the bundle so far. So Linda, are you here?
I am here. You guys hear me okay?
We hear a bit of an echo though. I don't know if I'm the only
Okay,
one.
let's see if I can fix that.
Oh, I think it may have resolved itself.
You okay? No?
Yes, I think better.
Okay, great. Oh, I don't know. I can hear it. Can you? Sorry. Can you hear me?
I think, yeah, it looks like you're logged in twice, Linda. Are you on 2 different devices?
How's that?
Much better.
Okay, great.
Awesome.
Thank you. I apologize. I don't know what's up with my Zoom app today, but I am having video issues, so my apologies for that. So hi, so happy to be here to talk about our perinatal mental health program journey with all of you. We are UMass Memorial Health, Milford Regional Medical Center. Just a little bit about our OB unit. We generally do around 1,100 deliveries per year on average. We have 15 beds, including 6 LDRP rooms, 2 ORs, and a level 1B newborn nursery. I think what makes us unique is we are, I don't know, I guess you could call us a dying breed, in that most nurses on our unit are cross-trained in all areas. So we're not divided up into just L&D or mother-baby. We do everything, triage, L&D, we scrub and circulate in the operating room. We are trained in newborn care at delivery, including advanced NRP, postpartum couplet care, and specialized newborn care. So as the perinatal nurse educator, I am a busy gal. Our patient population, we do have a significant number of Ecuadorian patients, of Brazilian patients, and a smaller number of Haitian patients. You can see we do have an equality statement. I did kind of jam pack my slides in, so it's only because I know that these are going to be available to you. So I'll just kind of hit the high points, I think, as we go in the essence of time. Next slide, please. So our perinatal mental health task force team is primarily made up of bedside nurses. There was a real drive for change. And the ultimate success of our program really came from these dedicated bedside nursing staff and a strong desire to do more to serve them. The primary patient focus from the start has always been investigate our patient's history, evaluate their current health, facilitate getting help for them, and educating them and their families. And I know this is kind of a goofy picture. This is from Halloween, but it was one of the only ones I could find where most of us are represented here. In addition to myself, our Director of Maternal Child Health, Rose Galimi Hayes, we were the site champions for this. But as you can see, it really did come from staff nurses and our social worker, Dee. Next slide, please. So our program journey began about 18 months ago. We do have a pretty robust best practice committee, and perinatal mental health has been on our agenda for quite a while. At the time, our program was really comprised of just some inadequate screening upon admission. It was not perinatal focused. It was the same screening that was happening with every patient within the hospital system. Our referrals to social work were based on patient history, nursing judgment, and our inpatient education was really oversimplified. So within the next year, we created some attainable goals. We held brainstorming sessions. We did lots of research. And because our group was primarily comprised of staff nurses with, patient care jobs, we did a lot of Zooming. We did a lot of texting. We did a lot of emailing. But we did manage to get the job done. I would say a major happening for us that was wonderful was when we joined the PMH-C Mini-Collaborative last spring. So the meetings that we had and the things that PMH-C gave to us, the resources, the tools, the assignments that we used really helped us to stay focused on our goals and create those materials necessary for our program. We began our staff and provider education on perinatal mental health conditions, our new unit workflows, and our processes in September, and we just had our last education session yesterday. And we're hoping to launch everything in the next couple of weeks, fingers crossed. Next slide, please. This was one of the first assignments that we had, the Dreyer diagram, in addition to the priority matrix. And this was something we had never used before. We had to create our aim statement and then go on and fill in our primary drivers, our secondary drivers, and those specific ideas to test or change our concept. It really helped us to pinpoint what we needed to do, the actions that we needed to take, and it also helped us kind of divide and conquer, if you will. It was really nice to see kind of how our program, we wanted it to unfold on really one slide, one screen. So because of those two things that we did with them, we were able to set our goals into 4 key areas: prenatal screening and OB office workflows, maternity inpatient assessment and screening, postpartum inpatient education, and staff and provider education. Next slide, please. So I'll just briefly go through some of our challenges. So as far as prenatal screening in OB offices, and I do want to say one thing that I forgot to say before, being part of the Mini-Collaborative was a relief for me, mostly because I learned that every hospital is really in the same boat as us. Everybody wants to do more. We really revamped our entire program. Some hospitals just had sections of it, but everybody wanted to do things, but they just didn't know how to do it. So that was kind of comforting in a way. So again, with our prenatal screening and OB offices, some of the challenges that we found was adherence to the recommended screening schedule. Not everybody was using the EPDS or any type of validated screening tool. The standardized process, the documentation was a little disorganized, a little haphazard. Big issue, insufficient time during patient visits for thorough screening, discussion and referral planning. Big issues with the prenatal record. Documentation was definitely haphazard, and the office staff definitely needed some education on most of these things. One thing I do want to say is these problems are not from a lack of caring or awareness by OB providers and staff. These are just systems issues. Everybody wants to do better. They just need to know how. Something we did with our prenatal records was some old-fashioned audits. So we were able to collect a lot of data this way. We went through, I don't even know how many prenatal records, tons and tons and tons. We went through them to see what type of mental health information is included in the record and where is it documented. Anybody who's ever tried to print a prenatal from Epic or any other EHR knows what I'm saying, because sometimes it's really hard to find that information. So what we did was we used this information to present to our office staff to say, listen, we have to do a better job here. Okay, next slide, please. So our accomplishments are we kind of figured out what needed to change in the office, and in conjunction with our director of case management and another member of our team, we had in-person visits to OB offices to review those recommended screening timeframes using the EPDS, documentation of mental health conditions, and standardizing the referral process, and also adding social work notes into the prenatal record, because a lot of our patients were getting treated or were getting help, but we didn't know that. So upon admission, we don't have a great picture of what's going on. Next slide, please. So inpatient screening, challenges here also. Our admission mental health assessment was not adequate or appropriate for pregnant and postpartum patients. Again, we weren't getting a great history through the prenatal record. We also don't have a validated screening method in our current EHR, nor did we have one we weren't even able to get one. Our process for referring patients for social work was kind of a little haphazard, really. A lot of it relied on nurse judgment. We hadn't had any education on a lot of these things, and many patients were slipping through the cracks. Next slide, please. So what we decided to do was, and we're not alone, and we learned this from several other hospitals that were in the PinQuin Mini-Collaborative, and this was the second PDSA cycle that we did. We are using the standardized screening tool, the EPDS, along with other trigger questions, and that this will become part of our postpartum assessment. But what we're doing, instead of, asking these questions to a patient while you're standing over them, typing into a computer, potentially with an interpreter, it will be privately completed on paper by the patient on their own time and in their own language. So we took those questions along with some other trigger questions, kind of reformatted it so it doesn't look like, this technical form that you're filling out, with the registry or something, and we have it in a clipboard at the patient's bedside so that she can read it, she can look at it on her own time. And then we also added in that clipboard the PSI, patient information sheet, where our goal, we're kind of hoping that if a patient opens this up and she looks at it and she sees that information on the PSI sheet, that before she answers those questions, she'll be like, I need help, and it is common, and it seems like I'm not alone. Maybe they're apt to answer a little bit more honestly. The other thing about having the patient, us creating this and doing this on paper, is that we can print it in any language that we want. So a patient can do it in their own language on their own time. Next slide, please. So yes, we have to put it into the medical record. So our IT liaison for our OB department created the fields for the EPDS so that once we review the form with the patient, we can go back to the desk, and then we can go ahead and do our documentation, and we just enter her answers, and it will calculate a score. So if that score is greater than 10, it will automatically send a social work referral and notify the OB. And it does it automatically. So, we're really standardizing the way that we do that. This will also ensure that screening, patient education has been completed before discharge, and it does provide that standardized screening for all patients. Next slide, please. Inpatient education. So challenges. Our current education was really lacking necessary information on, perinatal mental health conditions. It was really kind of mostly just about baby blues and depression. It didn't really, have that wide range of things that patients really need to be looking for or what we wanted them to know. So we also didn't have any really great self-awareness screening tools for when they went home or giving them good resources. We didn't have things in other languages. The couple of nurses who kind of took on this inpatient patient education project for themselves, our goal was initially to create something within our hospital, right? Like create resources. We were going to talk to marketing, make a QR code. We had all these things. And then we stumbled on the PSI patient information flyer. It's really wonderful. What this does is it does have all of the information that we want to impart on our patients, including that little self-assessment questions. It has a synopsis of the perinatal mental health disorders, and it also has this lovely QR code. So when you scan the QR code, the first thing it says is, get help. And patients can get help. There's 60 languages, they can text. It also has support organizations on there, and it's so local. It even has our support group that is affiliated with our own hospital. So we really, really like this. It is available in other languages. And not only that, but for nurses who are apprehensive about educating their patients on perinatal mental health, it provides a guide for them. So we're all giving everybody the same type of information. Next slide, please. So this was the first PDSA cycle that we did. This is one of our assignments within our Penguin Mini-Collaborative. And I was like, okay, I felt like as the educator, we should have been doing this right along. So this was the first one that we did. So what we did was we wanted to ascertain nurse satisfaction with using that PSI patient resource sheet for inpatient education. So instead of saying, yep, all the nurses are going to do this, we trialed it, right? We wanted to see how it went. So two of our task force members, they took mother-baby assignments for an extended period of time, and they went ahead and they used it. So for education, they demonstrated the QR code, and immediately when they came out of the room, they filled out a survey. So as you can see under the results, what we wanted to know from the nurse was, did the RN feel educated enough to review information? And the red is the result. They agreed. Was the nurse able to answer the patient's questions, or patient had no questions? Yes. The RN felt the patient was engaged or interested in the education, completely, somewhat. RN was able to demonstrate the QR code and the PSI app. Yes, no. This is what I really wanted to know. The RN is able to complete the education session in a reasonable time frame. Yes, 100% of the time. And this is also very important to me. RN satisfaction with perinatal mental health education experience. Was the nurse fully satisfied or somewhat satisfied? And it was 100% of the time they were either fully or somewhat satisfied. So all in all, it was really a big win. So we were really excited about that, and I'm kind of anxious to do another PDSA cycle the next time we have a project like this. Okay, next slide, please. So staff and provider education challenges, we didn't have any. So what we did was we created a 2-hour in-person education session for all unit staff, and we held it at 9 different times. We just held our last education session yesterday, and that education included current issues with perinatal mental health, a review of all of the conditions that we're talking about, all of our new materials, and all of our workflows. We just had a follow-up meeting about it this morning. Excuse me. And someone had asked me last week, what's been the response, about this? Like, what do they think? And honestly, the overwhelming feeling has been relief, that the nurses feel so happy to finally be doing something about it. Everybody wants to do something, but they didn't know how. So, we really worked hard to create a program that worked for us. what we're doing doesn't work for every hospital. But having it come from bedside nurses, being able to implement it into our workflow has really, I think, put a truly positive spin on all of this. So next slide, please. Okay, so we did it. Great. Now what? So another one of our last assignment with our Penguin Mini-Collaborative was using the sustainability planning worksheet. And I'll be honest, this was my favorite assignment. Only because, as the educator, I've been doing this a long time. We've implemented a lot of changes, a lot of programs, a lot of new things. And then it's like, okay, you do it, and now what? We don't have a huge, we're not a big organization. We don't have a lot of, quality, OB quality people, or, it's kind of just us keeping tabs on things. So for me, this was wonderful because we really had to answer a lot of these questions about what happens now, who's in charge of it, what will we continue to measure, what if things aren't working, who's going to own it, who's going to make those decisions. So it was really, really great. And I'm already planning to use this for another project that we're doing right now. So yeah, it was great. Okay, I think that's it.
Wonderful. Thank you so much, Linda, and congratulations to you and your entire team on all the incredible work that you accomplished. And it makes us happy to hear how helpful the Mini-Collaborative was to your team. And I do want to plug that all the tools that Linda has shown, the sustainability planning worksheet, the PDSA cycle worksheets, the driver diagram, all of that's available on the Penguin website. We can send it to you directly if you're having trouble finding it. And we can meet with you to do what we did in the Mini-Collaborative and just walk your teams through how to use these things and how to go through these cycles and make similar progress to the Milford team. So thank you again, Linda. This was terrific.
Hey, you're welcome.
You're getting lots of love in the chat as well.
Okay, great.
All right, we're going to move on to our last presentation with the BMC team. And do just want to say we'll have about 10 minutes at the end for Q&A. So if you have any questions already, feel free to put them in the chat and we'll get to as many as we can. All right.
All right, thank you very much. That was incredible. That was incredible to hear, by the way. So very impressive work. So my name is Maithri Ameresekere. I'm Director of Women's Mental Health at Boston Medical Center in BU. And I'm lucky to be embedded as part of an integrated behavioral health team at BMC in the OBGYN department. And we have a number of different services that we offer. I'm a psychiatrist with specialty in reproductive mental health and trauma. We are able to also offer individual therapy and some group-based offerings and culturally specific group-based offerings as well, all within the ambulatory OB space, which we're very lucky to be able to do. And Kayla, do you want to introduce yourself as well?
For sure. Hi, everyone. I'm Kayla Jennissen. I'm the project coordinator for the reproductive mental health program at BMC.
All right. Next slide, please. And this is the BMC DEI statement. If you can go to the next slide. So I think today we're going to talk about implementation of a different screener, the Refugee Health Screener-15. And I think it's helpful to talk about a case vignette to when we're talking about screening. Being a clinician, that sort of anchors me a little bit when we're thinking about screening. Essentially, we're screening to identify mental health problems, get people connected to treatment so they're not suffering in silence. And so I wanted to share a brief case vignette that sort of shaped our conversation around the transition to the RHS-15 as part of the Refugee Women's Health Clinic. And I think the director of our RWHC clinic is also on the call as well, which is exciting. So this is a Black 24-year-old Haitain Creole speaking woman. She recently migrated from Haiti, and she presents for her 6-week postpartum follow-up. You are an OB provider, you enter the room and you notice that she's tense and tearful. You contact the phone interpreter to communicate with her, and she discloses a traumatic and difficult migration journey. And she also reports distress related to living in a hotel as she has no place to cook or prepare healthy food. And she was provided a Haitain Creole translation of the EPDS on arrival to the visit, but she says that she doesn't fully understand the questions that it's asking. And so this is and was a common occurrence that we saw in clinic. Next slide, please. So just to give a little bit of background around incidence within this patient population, and specifically we're talking about displaced migrant population. The literature shows that this group are at elevated risk for perinatal depression, with the literature talking about rates between 11 to 60%. And additionally, there are also elevated rates of PTSD, particularly for refugees and asylum seekers. And there are a number of risk factors associated with this increased risk. Pre-migration trauma, which includes the man-made or natural disasters before departure, peri-migration traumas, including a dangerous and difficult route to a host country, and then post-migration stressors, which include social isolation, stigma, experience of racism, and difficulties in acculturating to a completely different environment, healthcare system, institutions. And that is added on to pre-existing perinatal mental health risk that you are all aware of at this point. Next slide, please. And so Boston is one of the top 3 receiving cities for Haitian migrants in the US. And in 2023, the OBGYN department saw a new patient volume increase of 30%, in large part due to the migration crisis. And so the Refugee Women's Health Clinic embedded in the OBGYN, or that's in the OBGYN department, provides perinatal and mental health services, saw a 225% increase in patients who speak Haitian Creole. And with that increase, there was a recognition of the importance of using culturally informed tools to be able to accurately detect mental health problems. Next slide, please. So the commonly used tool, which is the EPDS that we're now all pretty familiar with at this point, it's a focus on perinatal depression. It's validated in a number of languages. This list is not exhaustive, and it's translated but not validated in a number of languages as well, and that includes Haitian Creole. And so when we're talking about a validated screening tool, what do we mean by that? We're talking about a test that is able to produce consistent results. It's able to produce, the instrument produces true results, and it's sensitive, and meaning that the probability of correctly identifying a patient with the condition is present after completing the screener. And so given that this was not validated in Haitian Creole, we were noticing clinically a number of issues with it when people were completing it. And I recently actually went through with our with different Haitian Creole staff members the actual questions, and it seems like even questions such as the thought of I have been able to laugh and see the funny side of things, they were not sort of clearly understood in the translated version of the EPDS. And similarly, the question number 10, which is around suicidality, the translation was described as sort of vague and confusing. And so that could lead to problems of like over-reporting or underreporting around suicidality and various escalations of care. Next slide, please. So the decision was made to sort of, with a very complicated and process around it, but to use this other screener in the Refugee Women's Health Clinic. And the reason it was selected was a few different reasons. One, it's a culturally responsive, efficient, validated screening instrument. It was validated in Haitian Creole. It can detect symptoms of anxiety, depression, and PTSD amongst forced migrant refugee populations. And it was actually also validated in a perinatal population as well. And clinically, since it's been rolled out, it's been, what I've observed is that patients seem to understand the questions more easily it requires less explanation of staff, from staff, I mean. Next slide, please. And so there was, as I mentioned, a long process in terms of planning, identifying the screener, providing trainings in the Refugee Women's Health Clinic, developing protocols related to administration of the screener. And this was paired simultaneously with the launch of specific Refugee Women's Health Clinic behavioral health services. And we also recognized sort of later on that Haitian Creole speaking patients that were recent migrants were actually being seen throughout the OB department, not only within the Refugee Women's Health Clinic. And so that it was important to think about how could we have a validated screener administered for those patients as well who are not specific to RWHC. And so in the past year, we've been revamping and revising our own perinatal behavioral health screening guidelines to make it a clear algorithm for referral and escalation of care. And I'm going to pass it over to Kayla to chime in. Next slide.
All right, thank you, Maithri. So yeah, just talking a little bit about the perinatal behavioral health guidelines. This is our timeline for how we created the guidelines. And really they're meant to help providers decide when they need to screen a perinatal patient, which screening tool to use, and the next steps they should take depending on the patient's score. So we started drafting the guidelines in April of this year, and it was based on ACOG and MCPAP guidelines, as well as literature searches. We also got input from the Refugee Women's Health Center team. So the next step was stakeholder engagement, and this included meeting with OB leadership, medical assistants, front desk staff. We even had an IBH operations manager observe the workflow of medical assistants to understand where there were challenges related to screenings and inputting those scores into Epic. So it was at this point that Epic was also engaged to make it easier to input the screening scores into the system. Next, it was just more revisions of the guidelines based on stakeholder feedback, and it was also reviewed by the Maternity Care Guidelines Committee. And once it was approved by that committee, it was published in October. And so we're now on to the next steps, which includes implementing the guidelines in the OB department using the PDSA model. Next slide, please. So this is just a quick snapshot of the algorithm that we created. It's included in the guidelines, and the providers can use this and just follow it. Next slide, please. And this is our implementation plan for the guidelines. So we'll start with a retrospective evaluation of the screening rates, and then we'll also take a month to do education and training sessions for medical assistants, front desk staff, clinicians, and social workers, just so they can become more familiar with the guidelines. This will be followed by implementing the guidelines for 1 month. And then once that month is done, we'll gather feedback from the clinicians and the staff members. And we'll also take a look at the outcomes that we're measuring, including the monthly screening rates for EPDS, PHQ-9, RHS-15, and 5Ps. And we'll also look at the number of monthly behavioral health referrals following a positive screen. And so finally, we'll revise the screening protocol and the guidelines if necessary following the feedback. And we'll just kind of keep following this cycle until it feels that revisions are no longer necessary. Next slide, please.
There are many people involved in this whole process, so just want to acknowledge them. And this list is not exhaustive. That's it.
Thank you so much, Maithri and Kayla. This is terrific work, and I think we'll all be interested to hear how your PDSA cycles go. Maybe we can have you back.
I love this so much. When I talked about the other tools, I should have upfront said there are many criticisms around them, not the least of which is that many of them were originally developed for and validated in like very homogeneously white populations. And we see that we have a large Haitian immigrant and Haitian Creole speaking population too, and we too see those concerns.
We have reached the Q&A portion of this webinar. We have about 7 minutes, so I welcome anyone to put any questions they may have into the chat. You can raise your hand. Also welcome just any comments on screening, or if you're struggling with anything in particular at your institution that you'd just like to share and get feedback on. This is open time. Yes, Sandra.
Hi, I'm from Fairview Hospital in Great Barrington. I'm having trouble with parts of my computer, so I'm not able to type my questions. Thankfully, I have found at least 70% of these interventions and plans we already have in place. we're a very small critical access hospital. So our numbers are low, and it allows us to screen people in their prenatal antepartum. We have what we call a pre-admission tour, where we meet with every patient and talk in depth about depression, anxiety, and ask them about any kind of disorders or symptoms that they're having. My first question is, we've never received any information about red cap surveys. How do we go about that?
I can connect with you offline about that, Sandra, and we'll get that sorted out. It may be that we don't have the right contact for data submission at Fairview, so
Okay,
we'll reach out to you.
That would be great. Should I give you my email, or?
I can grab it from your Zoom registration, so I'll reach out
Beautiful.
to you.
Awesome, thank you. My other question is, my statement is the multilingual Edinburg and other screenings are very helpful, because we are an area of just many patients in migration and coming here, and very little care until they arrive. So that portion of that last presentation was very helpful. We just began this in September, so we're very early in our development, but these were very helpful about how to get the ball rolling, patient and staff education. I more so just wanted a contact person so I could communicate with you. So sorry I did it verbally, and I just don't have an area to type it in. So thank you.
No problem at all. Thank you, Sandra. We'll talk more. BMC team, there's a question in the chat from Lisa. How do providers decide which screening tool to use, the RHS-15 versus the EPDS?
Yeah, so we have a list of, so if the EPDS is validated in the language of the patient, that's the tool, because that's sort of common practice that's used, other than in the Refugee Women's Health Clinic. But if it's not validated, and there's also a difference between, not to get overly in the weeds about this, but there's also a difference between practices in the community health centers and then the main campus ambulatory department. But we have a list of the validated languages, and in the algorithm, it sort of outlines which tree you go down.
Thank you, Maithri. Lisa, feel free to come off mute if you have any follow-up questions about that, or yeah.
Thank you. All the presentations were amazing, as always. I was wondering if BMC would mind sharing that algorithm. And also, we've had trouble accessing the EDPS in different languages. I'm wondering where people get it.
I believe MCPAP for Moms has a list of the different EPDS validated and the translations as well, not validated. And then our algorithm, I'm happy to share, but it's still like continually being refined. So, but I would be definitely open to like chatting about it if that would be helpful.
Thank you so much.
Yeah, the MCPAP for Moms website, if you go on there, you should get access to links to a variety of languages.
Wonderful. So we have a couple minutes left. I'm not seeing any other questions. Mary, yes, go ahead.
Hi, thanks so much. This conversation is so timely. So I am a nurse coordinator at Healthy Start Systems with the Boston Public Health Commission. I'm not involved in the actual the bundle, just kind of piggybacking off the webinars. But Maithri, I'm so intrigued with all that work, because we have a BMC preventative medicine fellow that just started with it. Well, actually, she's been here almost a year, but we just rolled out a PHQ-9. You know, we haven't done that in the past for the home visiting clients, and she wants to do a focus group with our nurses on we have several Haitian Creole speaking, like native Haitian Creole speaking nurses, and we're finding the same thing, that the translation, they're telling us, a lot of the words just aren't making sense. So I think we're going to take a deeper dive, and I'd just love to hear more about what you're doing, and maybe if you can speak to our nurses at a meeting, maybe over maybe the whole staff, because our community health workers are also doing the screening too. But it was great to hear that how you're, delving into the interpretation of the screening. So I definitely want to find out more.
And I'm always happy to talk to anyone, so please reach out. And definitely our Immigrant Refugee Health Center are instrumental in this work as well. So it's been a extensive collaboration, but I'm always happy to talk about this stuff. So please reach out.
Yes, great. Thank you so much.
Thanks, Mary. Thank you again, Maithri. It is 1 o'clock, so I'll just ask, Grace with the last minute question. Curious how the translations of the EPDS were created. Does anyone have insight about that?
I don't know that I could speak to it with the level of detail probably required. I mean, there is, as was stated, there were those that were validated in those languages and those that were just translated. I'm not sure what the approach to translation was.
It was really a rhetorical question. My husband's a translator, so I see conversation about like bad translation don't do their job. And here's an example of bad translations not doing their job.
Yeah. Well, even if you look at the original language on the EPDS, it says like things get on top of me. Like even in English, it's a little bit.
I agree.
Even in US English, it's not sort of common vernacular, I think, for people to say that. So to then translate that is interesting.
Great. Wonderful. Tiffany, any final thoughts to wrap up this webinar on screening?
I would simply say I'm like really inspired by the work Milford has done. I'm really inspired by the work that BMC has done, and so needed, because yes, these are the screeners that are in the bundle and the ACOG clinical practice bulletin. Like, yes, that's where the greatest evidence is, but we know medicine has either completely ignored and or marginalized a lot of different communities. And so I think it's really important that we advance these efforts. So thank you for doing it.
Absolutely. Thank you so much to all of our presenters for today, and thank you everyone for being here. Wonderful work as always. Just a friendly reminder that we will not have a PMH-C bundle webinar in December due to the Penguin Summit taking place on the 9th. So we hope to see many of you there in person. And then our next webinar for the mental health bundle will be in January. And I'm looking really fast at my calendar to see what that date is. It will be January 21st at 12 p.m. We'll be talking about assessment and illness severity. So we look forward to seeing you all then. Thank you all so much.
Thank you.